Just a quick note to our guests as we wait. Several languages available in translation, interpretation: Arabic, Chinese, French, Russian, Spanish, International Sign Language. Just please click on the globe at the base of your screen, and we will begin in a few moments. Greetings. It's a day of dire news from the Middle East and devastating news as well from Afghanistan. It's a time of dire news from a number of nations around the world. I'm reminded of a prayer I heard once in a terrible war zone. Lord, give me a heart that breaks. As painful as it is, let us make sure our hearts break open and stay open to the struggles of the world. Only with open hearts can we do our work. On this day here, we've come together to launch a profound and urgently needed call for change, transformative change, in the way we try to help people struggling with crises of mental health. It's an honor to moderate this event. The honor is all the more meaningful because of the bold content of the mental health directive laid out by the World Health Organization and the United Nations Office of the High Commissioner for Human Rights. These are powerful pages informed by a desperate need for new directions. I know this need well, though not as well as a few of the people you'll meet today. As a young man, my brother, Bob, was put on locked psychiatric wards. He and our parents were told that he would likely take his own life if he did not stay on his medication that caused him debilitating side effects. Looming within his story, which I've told in my book, The Mind in the Moon, and which has driven my writing for the New York Times, are three pervasive, persistent mistakes that we are here to address. The mistake of involuntary mental health care, the mistake of an over-reliance on the biomedical approach to treating our psyches, and the mistake of our consistent failure to let the person who is suffering be the central decision maker in their treatment. After arrests and after homelessness, my brother's story is about triumph and accomplishment by any standard. When I ask him today what he would have wanted when he was in crisis, his answer matches perfectly with what this directive demands, with what we are here to work toward. This guidance represents a reconception of mental health care, but it does more than that. It sets out specific legislative and policy paths that governments and other policymakers can follow, paths that take us away from the involuntary and coercive, paths that lead us beyond the dominance of the biomedical, paths toward a deep engagement with the complex person and the complex causes of their pain, a true engagement with the person who longs for help, the person who, in their suffering, almost surely feels terribly alone, the person of genuine and unknowable possibility, of potential that cannot be measured, the person who longs for connection, not for imposed control. Congratulations and gratitude to the WHO and the OHCHR for this essential guidance. Special gratitude to Dr. Tedros Adhanom Ghebreyesus and to Mr. Volker Turk, as well as his predecessor, Dr. Michelle Bachelet, for their visionary work. Now, it's my pleasure to share with you a short video featuring the Scottish poet and performer, Erin May Kelly.
Two people crawl into two different mental health services. They both have dirt underneath their fingernails from when they clawed their way up, only to find they were still so far beneath rock bottom that the air was too stifling to ask for help. One of the people is offered an outstretched hand and a listening ear. They are given a tea with 2 sugars, just how they like it, and all the time in the world to tell their story. The room is as warm as the nurse's voice, and every decision is their own choice. The other person is given an unmarked pill bottle and a door that they don't have the key for, a meal they don't like, and a clock counting down to hopelessness. What happens to a person when they are treated as less than human? When they are treated like a tranquilized problem that needs to stay docile and become more prisoner than participant? In services where there are maroon-soaked nail marks in filth-ridden rooms, where restraint bruises are burned into shaking wrists, where people become a watered-down version of themselves. In cities, both flourishing and struggling, mental health services are turning away from respect and refusing to look human rights in the eye. Abuse, both screaming and silent, can be found in all corners of the world. How many times can a person be told they don't matter before they start believing it? This is not a problem tucked away in a shadowy part of the world. It's not a monster under someone else's bed. This is a problem within arm's reach, and we already have the instruction manual of how to put humanity into healthcare. There are too few services around the world where people are the heart of policy. These places are few and far between, but they are a shining beacon of hope to those who ask for help. Where professionals ask instead of tell. Where professionals treat the person and not just the symptoms. There are services which have been built by the people who once needed them. And clearly marked maps showing you how to step back into the community, allowing the people who asked for help to shape the path back into society. People remember when they are told that they are more than an illness. They will remember the power of their own name, and their problems will still be part of them, but not the part that wins. When respect and dignity are at the heart of healthcare, there are no shadowy corners or filth-encrusted beds, no bloody sheets and echoes of confused cries, no workers turning a blind eye. Nobody gets left behind in the dark as corners are cut. When consent is the only non-negotiable thing, we can build a system that heals more than it hurts. The power to save lives has been placed in our palms. You can reach into the tear-stained earth and pull life from the soil. You can be the difference between a life and a body. You can stop another success story from becoming an obituary, so another person doesn't crouch in the shower at the end of the day and try to scrub abuse from their skin, so they can walk back into society with dignity, to a life that they forgot they deserved. When human rights are the foundation of healthcare, you will save more than lives. We will save dreams, memories, passion, and purpose. You can stop someone else's time from running out. We can save thousands more stories if we just act now.
Let's turn now to the remarks of Dr. Tedros Adhanom Ghebreyesus. He's long championed mental health as a top priority, advocating for accelerated action and increased investment in this field. He's spoken out strongly against stigma, discrimination, and violence directed toward persons with mental health conditions. He's been a major force in calling for the transformation of the mental health system to align with a person-centered, rights-based, and holistic approach.
High Commissioner, my friend Volker Turk, Excellencies, dear colleagues and friends, this year marks the 75th anniversary of the founding of the World Health Organization. Since the beginning, mental health has been part of our mission. The first line of our Constitution defines health as the state of complete physical, mental, and social well-being. And the second line says health is a human right. Today, an estimated 1 in 8 people globally live with a mental health condition. And yet, most of them lack access to the health services they need. People with mental health conditions often face human rights violations, including stigma and discrimination, as well as coercion, abuse, or neglect in care. WHO and OHCHR are united in our call for mental health to be respected as a human right. The joint guidance we're launching today serves as a roadmap for countries to develop, implement, and evaluate laws that protect and promote mental health and human rights. This new guidance can catalyze legislation reform, opening doors to care and services that are person-centered, rights-based, and recovery-oriented. Protecting the rights of people with mental health conditions goes hand in hand with the need for countries to expand access to services for mental health as part of their journey towards universal health coverage. As we mark World Mental Health Day, we affirm what the founders of WHO affirmed 75 years ago, that health, including mental health, is a human right. I thank you.
So important to have that sense of urgency from the Director General. And with that, to Mr. Volker Turk, the UN High Commissioner for Human Rights, for his opening words. Mr. Turk has devoted his career to advancing human rights, focusing notably on the international protection of the rights of people in some of the world's most vulnerable situations. Prior to this, Mr. Turk served as Undersecretary General for Policy for the UN Secretary General, where he coordinated global policy work.
Excellencies, colleagues, friends, I regret that I cannot be with you in person. I'm delighted to be launching with the Director General, Dr. Tedros, this joint OHCHR-WHO publication. We are all aware of the enormous impact the pandemic had on mental health. Social isolation, economic insecurity, and fears around health triggered widespread anxiety and distress. Many experienced a decline in their mental health while struggling to access adequate support. The last few years, though, also cast a much-needed spotlight on the right to mental health, starting important conversations in countless homes, communities, and workplaces all around the world. It has been the catalyst for positive examples of transformation, from the move to counseling online and by phone, to the expansion of peer support initiatives, which recognize the unique role that persons with lived experience can play in supporting others. But the pandemic also acutely exposed the degree to which national legislation related to mental health in every region is based often on a coercive and institutionalized approach. Our new joint guidance is intended as a long overdue course correct. We hope it will inspire a new pathway for national laws and policies that are firmly grounded in human rights understandings and which contributes to the 2030 agenda vision, which is about better health and well-being for all. With an emphasis on personal dignity, equality, and rights, there needs to be a fundamental shift away from institutionalization towards inclusion, community-based support, in line also with the Convention on the Rights of Persons with Disabilities and the right to health. Our ambition must be to transform mental health services, not just in their reach, but in their underlying values, so that they are truly responsive to the needs and dignity of the individual, that they are enabling people to participate fully in their own recovery. And this demands a clear framework that ensures equality and non-discrimination in decision-making by individuals, including free and informed consent, and gender-inclusive laws that address harmful practices that are often faced by women, such as over-medication, forced contraception, and indeed violence. Dear colleagues and friends, this publication offers practical guidance on how a rights-based approach can support the transformation that is needed in mental health systems. It sets out clearly an alternative set of objectives for national legislation, along with the provisions needed to ensure access to good quality community-based mental health programs and services that are centered on the individual needs of women and men in all their diversity, with due consideration of age and culture. It outlines concrete measures to safeguard human rights, such as every individual's right to make decisions on treatment, eliminating the risk of coercion. And it shows how legislation can be used to dismantle stigma and discrimination. I'm encouraged by a number of governments who have already taken steps to reform their legislation and policies. And I urge all states to use this guidance as a blueprint for reviewing existing legislation and for designing new statutes. I'm confident this resource will be of support to the diverse group of stakeholders involved in advocating for and delivering better mental health provision, including, most importantly, people with mental health conditions themselves and those who have psychosocial disabilities. I'd like to express my thanks to all those who contributed to the consultations on this publication, and to our colleagues in WHO for their excellent and continued cooperation, in particular the Policy, Law and Human Rights team, and to all of you for taking part in this launch today.
Important words, but a quick technological note for our guests. Just be aware, please, that if you're having trouble with volume, please go to the bottom of the screen, press your language of preference. That includes if your language of preference is English. So that should take care of the problem, and you should then be able to listen to the rest of the program. I just want to emphasize before we move on the importance of Mr. Turk's words, especially as they bring together the practicality of this document and the visionary aspect of this document. I think what makes it unique is the convergence of those two elements. We can't really have one without the other. Vision gets us a long way, but it only gets us so far, and it's the practicality of the document that can take us toward real change. I'm really looking forward to this next part of the program. I want to introduce a panel of speakers who are upcoming here. Ms. Devorah Castell, the director of the Department of Mental Health and Substance Use at the World Health Organization, who is responsible for overseeing the global work related to mental health, brain health, as well as alcohol, drugs, and addictive behaviors. Dr. Michelle Funk, who is the head of the Unit on Policy, Law, and Human Rights in the Department of Mental Health and Substance Use, and the lead for the Quality Rights Initiative at the World Health Organization, which supports countries to develop services, policies, and laws in line with international human rights standards. Mr. Jared Klein, who has lived experience, who is a human rights advisor and head of advocacy at the International Disability Alliance. Mr. Klein was also a former legal advisor and diplomat for the New Zealand Ministry of Foreign Affairs. Mr. Jan Jarab is the regional representative of the Office of the High Commissioner for Human Rights, South America Regional Office. Mr. Jarab brings diverse perspectives, having previously led the Mexico Country Office and the Regional Office for Europe. And finally, Ms. Lynn Gentilet, who is a human rights officer in the Office of the High Commissioner for Human Rights. She is the focal point on the right to health and provides technical support on human rights-based approaches to health within the OHCHR as well as across UN agencies. Ms. Castell, let me ask you the first question. Just give us a sense of why this guidance on mental health and on human rights and law is so important.
Thank you very much, and allow me to thank you all for being here in the room with us today, Excellencies, colleagues, and from WHO, from the other organizations we work so closely with, and all those who are connected online. In answering to this question, I would like to start by saying a bit what Dr. Tedros already said, that mental health is an integral part of our general health and well-being and a basic human right. But we know that despite this, for too long, mental health and the support to people with mental health conditions has been neglected in many, many countries and has not assumed the importance that it deserves, and as a consequence, the investment that needs to have. There are extensive human rights violations. Many are exposed to poor quality services and inhuman living conditions, overcrowding in unsanitary facilities, lack of access to basic necessities. They are subject to treatment that are dehumanizing and to coercive practices, and we heard, thank you for sharing personal experiences as well. Lack of access to quality services is also a main issue worldwide. This guidance then is an important tool that provides guidance to countries on how to formulate law in a way that promotes ending these violations, showing how to promote, again, people's human rights in the mental health context, in the mental health field. I want to draw attention, though, to an issue that is particularly interested and important to me, and this is the situation of the psychiatric institutions. Still today, over 70% of total global government expenditure on mental health is spent in mental hospitals or institutions in low and middle-income countries, and if we move to high-income countries, this percentage is around 35%. Overall, these hospitals account for 2 out of every $3 spent globally by governments on mental health, where they should instead be invested in community-based services and care. We know from many reports that those institutions are associated with extensive abuses. Institutionalization is an example of one issue that this guidance is tackling by promoting the closure of institutions while supporting the development of alternative community-based mental health services and supports. This law guidance then is intended to help everyone in contact with the mental health system who may be at risk of rights violations or who is already suffering rights violations, but the guidance wants, to emphasize the rights protection with particular attention to the voice of those living right now in institutions. Thank you very much. Now back to you.
With that, Dr. Funk, your work here and WHO's work has been influential for me as a writer. So I know this guidance well, but can you tell us more about what's new, what's so urgent, what's different about this document?
Thanks very much, Daniel. I'd like to show a few slides in order to summarize the context and some of the key features of this new joint WHO-OHCHR guidance on mental health, human rights, and legislation. So let's first zoom in on the context for mental health in countries, which is essentially the backdrop in which this guidance is being introduced. I want to start by saying that we are seeing more space and many more opportunities for mental health reform in countries that have human rights at their core. However, as much as we are in a time of transition, excitement, and hope for what can be achieved, we need to recognize the many challenges and pressing issues that need to be overcome. They're not new. Here we're talking about institutionalization, lack of access to rights-based community mental health services, the use of coercive practices, violence, abuse, and neglect, and the denial of people's legal capacity and the right to decide over their own treatment and other key aspects of their lives. Stigma, discrimination, as well as the disempowering messages that many people receive within the mental health system is also a huge challenge to overcome. For example, in many cases, when people receive a diagnosis, they're often treated as being unable to actively participate and contribute to society, leading to further marginalization and exclusion. Another pressing issue is that of services placing too much emphasis on diagnosis and the use of medication in order to manage symptoms, rather than taking a holistic, person-centered, rights-based approach to treatment and care. In other words, an approach that recognizes people's aspirations for leading a life that has meaning for them and that supports people to be included in the community. All these pressing issues are either direct human rights violations or lead to human rights violations. And they're all factors that contribute to poor quality care and worsening mental health. Yet they are widespread practices that continue today in the services and in the community in all parts of the world. It's important for countries to take a hard look at what is happening in their mental health sector in order to decide on the actions that they can take to reform their systems so that they align with the latest international human rights standards and obligations, including those under the UN Convention on the Rights of Persons with Disabilities, also known as the CRPD. And this new guidance, which we are launching here today, helps countries to do just that in relation to national laws, thereby also setting a more positive tone and frame for broader action in mental health. The joint work between WHO and OHCHR to develop this new guidance is not coming out of the blue. Momentum has been building since the coming into force of the CRPD. And I've listed on this slide some important political milestones that countries have signed up to. Under the leadership of Dr. Tedros, the World Health Assembly endorsed WHO's comprehensive mental health action plan, calling on countries to reform their mental health-related legislation, in line with the CRPD and other international human rights instruments. It's also noteworthy that the UN Human Rights Council, under the leadership of Portugal and Brazil, have issued no less than 4 resolutions on mental health and human rights since 2016, calling for human rights-based reforms and new guidance for countries on policy, law, and services. More recently, in June this year, the UN General Assembly adopted a resolution on mental health and psychosocial support, which issued a similar call to member states. So, what do all these political milestones mean? They mean that countries recognize that change is needed and that they have committed to making this change happen. I've mentioned the political milestones, but it's equally important to mention the technical milestones that have been achieved over the past several years through the World Health Organization's Quality Rights Initiative. The rights-based guidance and tools that have been developed provide an action arm to translate political commitments into concrete actions for change. And on this slide, you can see the many different guidance and tools that we have developed. They have been evaluated and have shown large-scale improvements in attitudes, mindsets, and practices, as well as service transformation in line with reduced stigma and discrimination and a human rights-based approach. However, still more is needed at the policy and legislative levels in order to build effective, long-term, sustainable change. And this new law guidance represents an additional technical milestone along the pathway towards reform and bridges an important gap in guidance and practice on this important topic. So let me elaborate some more about why and how this law guidance is so important. This is the first time that comprehensive guidance has been developed to support countries to implement their commitments to the CRPD and other international human rights standards as they apply in mental health and also, importantly, as they apply in the context of national legal frameworks. These are areas that countries have been struggling with for years. The law guidance responds to critical questions such as, how can we safeguard people's rights even in crisis situations? What are the processes for respecting people's will and preferences, their choices? What concrete measures are needed to establish supported decision-making mechanisms, and how do we eliminate coercion? It also addresses head-on key questions around service-related issues. For example, how law can facilitate the development and expansion of community mental health services and other support services that promote recovery and rights, and how can it facilitate deinstitutionalization? The guidance provides clear examples throughout of provisions that can be included in law to address these key questions and challenges. Finally, the guidance outlines the procedural action steps and proposes a checklist that countries can use when reviewing, drafting, adopting, implementing, and evaluating mental health-related legislation. And here, let me emphasize the importance of engaging all stakeholders in law reform efforts, in particular, persons with lived experience, those who have interacted with the health and legal systems, and hence who know firsthand what needs to change and how it needs to be changed. Successful reform depends on this. I'd like to end with what I believe is an important point for reflection. We understand that countries are facing complex situations that impact severely on mental health. These include resource limitations, economic and social inequalities, discrimination, war, poverty, climate change, and pandemics. Mental health is therefore an important priority in this context. More needs to be invested, and this investment must be directed towards rights-based approaches in order to have better health and social outcomes. We can't afford to maintain the status quo. We recognize that this guidance and law represents a significant departure for how legal frameworks have been developed and applied in recent decades. We are also fully aware of the complexities involved in effecting change, particularly when historical precedents and entrenched structures can present huge barriers. Nonetheless, we urge all countries to engage in a critical examination of their existing legal frameworks related to mental health, especially those that may inadvertently perpetuate human rights violations and inequalities. We also encourage all stakeholders to actively engage in collaborative discussions on how best to utilize this guidance in fulfilling the diverse range of political and human rights commitments that have been made. Thanks very much.
Thank you. I just want to emphasize the Thank you. I just want to emphasize an emotional element beneath those very necessary technical legislative elements, and that is, in no other area of health that I can think of do we as societies decide that the person in need of care or wanting care should or may have no particular input on how that care is given or what care is given. In no other area, except currently in many places, in many societies, in the area of mental health. So much of this guidance goes to address what I think to all of us seems an obvious human rights problem, violation. And with that, to keep us somewhat on the emotional, Mr. Jared Klein, who speaks both from lived experience and from the perspective of the International Disability Alliance.
Thank you so much, Mr. Moderator. I'm usually known to be more technical, but I'll go for some emotion as well. So in terms of the types of violations that we see, they were well listed in the slides before. The point is that they are deeply embedded in mental health systems. They include lack of respect for legal capacity, lack of respect for physical and mental integrity, informed consent violations, forced medication, deprivation of liberty, involuntary hospitalization, the use of physical restraints and seclusion, wide-ranging physical, emotional, and sexual violence, violations of sexual and reproductive rights, and denial of access to justice. It's a long list. It's somewhat technical. Beneath it lies immense human suffering. These violations can cause significant lifelong trauma and distress, exacerbate mental health issues, and lead to a deterioration of overall health and well-being. The use of coercion drives people away from the health system. It perpetuates stigma and negative stereotypes about people being potentially violent and dangerous. My own experience was very much in line with all of the above. Perhaps it is an all too common story. I'm a survivor of institutionalization and a person with psychosocial disabilities. In New Zealand, some years ago, on the basis of a diagnosis of bipolar disorder, during a manic episode, I was deprived of liberty for 90 days. I was held down, tied up, forcibly medicated, placed in a seclusion cell. I was subject to various forms of violence, with the power of the state being used to try and impose normality on me, supposedly for the benefit of my mental health. The impact of deinstitutionalization was traumatic, violating my rights and not positive for my health in the long or short term. I felt deeply wounded by the indignity of being deprived of liberty, even through the forced and aggressively heavy sedation and other drugs, a kind of chemical restraint. I longed to be free. I could not understand what I had supposedly done wrong. I often asked how I could get released, but I also recalled from my legal studies just enough to know that a legal review would be lengthy, costly, and pointless. This experience would tell anyone that the law and policy was deeply wrong. It was clear then, as it is today, that the ableist ends of mental health policy cannot justify the coercive means. As for why we need to eliminate these practices, the answer is simple. The practices are wrong, morally, legally, and in policy terms. It is not enough to try and improve conditions, try to eliminate bad practices. By design, the legal and policy underpinnings of current mental health frameworks are inherently flawed. The fundamental approach to mental health must change. My experience in an institution, then in my career as a civil servant, diplomat, and then NGO worker has been trying to understand the power and the limits of the law as a tool to shape people's lives. This groundbreaking guidance charts a path forward for health systems globally. It shows us that the law can be more than a shield for the individual against the misuse of state power. It can be a tool to transform societies, to help generate and sustain paradigm shifts, and to ensure ultimately that we are all truly free and equal in dignity and in rights. Thank you.
Thank you so much. And now to Mr. Janjarab for some words about actually implementing these changes.
Good morning from Chile. Do you hear me? It is.
Yes, we do.
Yes, it is indeed very encouraging to see that WHO and OHCHR are, after all these years, finding a common language in this guidance to bring human rights to the area of mental health. We're often asked if countries can actually afford to implement the recommendations in this guidance when they grapple with resource constraints. And as the publication itself acknowledges, countries are at various stages of developing their mental health care systems. So there can't be a one-size-fits-all approach. But it is crucial to understand that we are speaking about obligations that states have as duty bearers towards a group of rights holders who have too long been neglected, discriminated against, and denied their rights. Lack of resources cannot justify keeping persons with psychosocial disabilities in inhuman or degrading conditions that are often encountered in residential institutions worldwide, even in otherwise quite developed countries. And it cannot justify knowingly accepting bad solutions. It cannot justify abandoning these rights holders. Coercion and institutionalization are not just a human rights issue, but they're also very costly. They require an extensive physical and service infrastructure that isn't necessarily centered on the persons that it should serve. Thus, institutional care is a very inefficient form of spending resources in mental health. And there is evidence that person-centered, community-based care can provide better quality and more respect for human rights than institutional care at a comparable level of cost. On the other hand, good community-based care requires resources. And we should all be cautious of narrowly economic-minded arguments that sometimes emerge in the deinstitutionalization debate. It should not be the dominant argument. If it takes over and argues that states should end institutionalization mainly to save money, we risk that institutional care will not be replaced by community services, but by non-existent care. And there are some lessons learned from the economically motivated rapid closure of mental health institutions in some highly developed countries, with people then finding themselves without adequate care, often homeless. Thus, it is important that resources which are saved in the institutionalization processes, are ring-fenced and invested in services and support that are necessary for recovery and community inclusion. With respect to low and middle-income countries, many are currently undergoing health and mental health reforms, sometimes linked to universal health coverage objectives, which can be leveraged to ensure the changes required to implement this guidance. By embracing progressive legislation related to mental health, they can avoid investing in costly and problematic systems. Start from a conscious choice of systems that are more inclusive, advance equality, and are effective in addressing health holistically. Investing in community-based approaches, in community networks, peer-led initiatives, can enable the development of solutions that are also culturally sensitive, locally relevant, and people-centered, and promote gender equality, while also making economic sense. Moreover, integrating mental health into primary healthcare, education, and social security policies can free up resources for the full use of maximum available resources and ensure that mental health and well-being are embedded in all of these sectors' work. International cooperation can also play a useful role. Countries can learn from each other, looking at examples of a human rights-based mental health sector reform, such as that in Italy following the Basaglia law, but also in countries such as Brazil, while also learning to avoid the pitfalls of badly prepared reform processes. We're also seeing encouraging legislative changes in countries like Mexico, which has adopted legislation reinforcing the protection of human rights in mental health services, including by prohibiting coercive practices, or Peru with recent legislation aimed at overcoming guardianship and transitioning to supported decision-making options. This guidance shares many of these examples and shows that there is potential for propitious legal and policy frameworks that can transform our societies for the better of everyone. Thank you for your attention.
Thank you. And now Ms. Lynn Gentilet, who's going to speak to us about how to implement the changes we're here to begin developing.
Thank you, Mr. Moderator. Good afternoon, Excellencies and ladies and gentlemen. The legal framework plays a vital role in protecting rights, and as such, it's a powerful determinant of the right to health, including the right to mental health. But even the most comprehensive, most thoroughly consulted laws will only be of benefit if there is effective and consistent implementation. I wanted to touch today on three broad areas which can help to ensure this effective implementation. Number one, human rights compliant policies. Policies, along with laws, have a direct bearing on the enjoyment of human rights, and consequently, an enabling policy environment grounded in human rights norms and standards, including those specifically relevant for persons with disabilities, is also needed if laws are to be appropriately applied. Number two, training. Stigma, myths, and misconceptions associated with mental health conditions and psychosocial disability often impede the implementation of rights-based legislation, and this has significant negative impacts on persons using mental health services. Awareness raising among the public on mental health and human rights training for health officials, law enforcement agencies, social workers, teachers, and others involved in implementing legislation are examples of tools for tackling stigma. In addition, a comprehensive knowledge and understanding of applicable legislation is indispensable for all professionals who work in mental health. And finally, accountability. As well as the right to a remedy for human rights violations, effective accountability involves a diverse range of actors within and beyond the health sector and requires multiple forms of oversight and review. Independent monitoring is one of the cornerstones of accountability, and frameworks for monitoring the rights of people using mental health services may include health review bodies and national human rights institutions. Implementation is not the responsibility of the health sector alone. Indeed, different entities may have monitoring functions and other roles under mental health legislation, and the overarching monitoring framework will need to reflect and provide for the competent management of this integrated responsibility. Both anecdotal evidence and empirical research suggest that many mental health-related laws are ineffective, and so the continuing real-time evaluation of laws needs to be built into the accountability cycle, with legislation and its impact reviewed on a regular basis. The meaningful participation of rights holders should be part and parcel of evaluations. And ultimately, monitoring and evaluation outcomes should result in legislative and policy responses that are adequate to the task of protecting the rights of the users of mental health services. There are many other examples that we'll find in the guidance on successful implementation, but we trust that this resource will become an important one for all stakeholders. Thank you.
Thank you so much, Ms. Sontele. And back for a moment to Jared Klein. Can you just summarize or give us a few takeaways that are most urgently needed to you?
Thank you, Mr. Moderator. I mean, for me, the immense importance and potential impact of the guidance can't be overstated, and I have 3 points on this. First, the guidance must help change the way states think about and understand mental health, psychosocial diversity, and human difference. The time to apply the paradigm shift to end coercion and eliminate power imbalances in mental health is now. I would say to states, stop paving the road to hell with your supposedly good intentions. As the guidance says, a human rights-based perspective embraces human differences and recognizes individuals experiencing distress or unusual perceptions not as having a problem that needs to be cured or fixed. Second, to policymakers and government officials, please read every word of this 207-page document. Apply it fully together with the checklist. There are no more excuses. Follow this guidance. Use all the quality rights tools for training and guidance. Implement your obligations under the CRPD. Apply all CRPD standards, including the guidance on deinstitutionalization. Third, we cannot change the past, but as we move forward and implement this guidance and those CRPD standards, states must also admit wrongdoing and consider moral repair, remedies, and transitional justice measures for persons with psychosocial disabilities. This includes meaningful participation of persons with psychosocial disabilities and their representative organizations in this badly needed reform and beyond, building on the following critical parts of the guidance. 1. Every person should be allowed to define their own lived experience. A diagnosis should never be used to deny or limit rights. 2. It is necessary to challenge biomedical models that reduce mental distress and diversity to illnesses, and also to reassess the role of mental health services in people's lives. Finally, options that fully respect the self-knowledge, will, and preferences of the individual should be made available outside of the healthcare system as primary services without the need for mental health diagnosis or treatment. To conclude, I would like to acknowledge all my fellow survivors of institutionalization. To those still in institutions, I call out to you in solidarity and say to the world that none of us are free if even one of us is chained, physically, legally, or chemically. With the help of this guidance, I hope one day soon, every institution in the world will be closed and coercion will be a tragic legacy of the past, but not part of our future. Thank you.
Again, a deep thank you. And 2 quick thoughts. One, I worry sometimes that people even in high positions in large organizations where many of you work, or certainly people working within those organizations, may feel a kind of, I I don't know, just a sense that your words aren't reaching the rest of us out in the world. I want to just emphasize not so. So this guidance, as well as a previous document that WHO published, both were very important to me as I gained editors' belief in the urgency of some of these issues, and so ended up gaining a lot more attention than would have otherwise been offered within the pages of the New York Times. So although we're talking about legislation and necessary changes of policy, I just also want to stress there are cultural ripples that happen through a document like this that are important to note and are important notes of gratitude from me. The other thing is just to pick up on this note about the past. And so as I learned from having great candid conversations with many psychiatric researchers who had devoted their entire long careers to searching for the perfect medications for various serious mental health conditions, we have run into a bit of a wall. Many would say to me that for at least half a century, and some would argue for 70 years, we've made really little substantive progress in finding those much more effective and much less side effect heavy medication. So that leads to the obvious question. If we've spent 50 or more years just in a way standing in place, is it not time to make some really fundamental changes in the way we think about mental health, in the way we reach out to those who are in crisis? So I just want to echo Mr. Jared Klein's urgency about it being very much time to make some very fundamental and profound changes. And that leads me to our next panel. So I've really been looking forward to this because it includes someone who I've just begun to get to know, Ms. Hawa Ojefo, who is the founding executive director at She Writes Woman Mental Health Initiative. It's a movement that gives mental health voice in Nigeria by empowering people with lived experience to tell their stories, to co-create solutions, and to advocate for their rights. Hawa is a renowned human rights activist who is popularly tagged the voice of mental health in Nigeria. Hawa uses her expertise and lived experience to advocate for people with mental health conditions and psychosocial disabilities. She made history as the first person with a mental health condition to testify in that capacity before the Nigerian parliament. More on that in one moment. The other person who'll be joining us on this panel, I've known for quite some time, and she, alongside my brother, really is, the two of them are the central narratives of the book I've recently published, and that is Caroline Mazel Carlton. She is someone whose personal experiences in psychiatrists' offices, in hospitals, and in jails made her long for a better world. She has facilitated trainings for human rights and harm reduction approaches to mental health, such as, for just one example, alternatives to suicide, in North and South America, in Australia, in Europe, and in the Middle East. She is a worldwide leader. Caroline is the director of learning for the Wildflower Alliance, and Wildflower, in turn, is the home of the WHO recognized and celebrated peer respite called Afia House, which we'll also hear about more in a moment. Caroline does extensive training and facilitation for the Hearing Voices Network. She has contributed to multiple academic publications, and I will add, she is featured in a notable book about stars of roller derby. We'll hear more about that in a sec. I want to emphasize in advance, though, that if we want to think about creative ways to cope with serious mental health conditions, Caroline has lots to offer And it turns out, as I learned as we spent so much time together, roller derby was one such way. We'll get to all of that. Hawa, you're first. You're a Nigerian and a world leader in rethinking mental health care, and you spoke so powerfully to policymakers and practitioners when you said recently, "You cannot know more about my condition than I do." This is the bedrock of person-centered care. So I'm hoping you'll share some of your story and how it has felt to have other people believe that they know more about your condition than you do.
Thank you very much, Daniel. It is a pleasure to be here today to share of my story and just to dive straight into the answer to that question. I mean, within the past year, I could start talking from years before, but within the past year, I recall having a conversation on radio, and the host had me and a psychiatrist who leads one of the biggest psychiatric facilities in Nigeria to speak on Nigeria's mental health law after it passed in January of 2023. So this is the first mental health law that Nigeria has had since 1958, the Lunacy Act of 1958. And I made a comment about people with mental health conditions being experts by experience. And the conversation blew up from there, from my condition being likened to malaria, to a very aggressive assertion of the ongoing power dynamics, psychiatrists have over people with mental health conditions. And here's the thing, this happened this year, 2023. So it's just evidence to show that that power imbalance and dynamic that exists predominantly in the mental health system, that this is what happens when mental health care is not person-centered. And this has been my reality. Many psychiatrists have discounted my life experience, my lived experience. For their many years in medical school, I remember the psychiatrist telling me, "You do your job, let me do mine." And it was really shocking, and it really did shake me that day, because I really stopped and I thought about it and the consequences of just that simple statement and the ideology and mentality that it transcends within the space. It was me, a person with a mental health condition, being told in plain words that I do not matter in my own care, that somehow patient rights didn't quite apply to me. And so this guidance, I believe, could offer what could be a game changer. And here's why. I still maintain that no one knows more about my condition than I do, because with mental health conditions, lived experiences vary. I could and I did through various international human rights laws and local laws, to assert my position, my rights. But it's different now with these guidance, right? You know why? Because health practitioners in particular prefer to listen to health organizations say exactly what we have said for many years. So even though it still feels like, oh, hey, look, we're not being heard as people with mental health conditions, it feels like we're taking several steps forward now that there is a bit of backing with it. So it has been quite a roller coaster, Daniel, just living with that idea that, you don't know much about your condition. I spent 7 years in medical school. You can't tell me what to do. And that sense of what it does to a person, where you live your life feeling that everybody else knows more about what you're going through than you do, and it ultimately affects your care, your support, and your life trajectory, your ability to participate in political, economic, social, cultural aspects of your life as well. So yeah, it has been daunting to accept my position. It has been daunting to hear that over and over again, to be insinuated, to have it in words, but also in practice and in actions, where I am diminished because, I'm not a professional of my own experience. But I do still maintain that no one knows about my condition more than I do.
Yeah, I just want to, before turning to Caroline, just linger on two phrases: the Lunacy Act of the 1950s, and then the phrase that you just came up against, "You do your job, let me do mine." And it's so easy for us to think, oh, the past is past. The Lunacy Act, that says it all about the 1950s. We're not there anymore. We've progressed so much. But really, if you listen to the next version of that, "You do your job, let me do mine," it is not so different from the lunacy label. It's a complete dismissal of one's own self-understanding. It's painful to hear how, and I'm really glad that you shared that. Caroline, so much to talk about, but before we talk about your life today, as a leader today of a U.S. and world movement, can we go back to the beginning? You heard voices from a very young age. What part has the dominant biomedical model played in your life?
Thanks, Daniel. Yes, I started hearing voices at a young age, voices that other people didn't hear, particularly a man's voice. The voice would get very angry when I would be abused by caregivers. And this voice would also yell extremely loudly, very terrified statements when I was exposed to footage of the Gulf War as a child, particularly the bombings. So basically this voice, hearing this voice, he was so scared that he wouldn't let me sleep at night. So I was brought to a psychiatrist when I was 8 years old. I was told that he was an expert, a doctor, but he had actually never heard voices himself. And he didn't ask me much about the voices that I was hearing. So before I met the biomedical model, my main fears were being abused and people dying from bombs. After I met the biomedical model, I was still afraid of those things, but I also became afraid of hearing the voice. I was afraid because I was told that the voice meant that I had a neurodegenerative disease. And after I met the biomedical model, I also learned that the world was afraid of me. They were afraid of me because people thought I was psychotic and dangerous. And that was really lonely. The doctors did prescribe a lot of pills. And I think that me being given pills, it made other people feel better, like less afraid of me. But taking the pills did not solve my problems. They didn't stop the war. They didn't stop the abuse. Basically, it just slowed my mind and body down. I gained a lot of weight. And so my voices, they sounded like they were underwater, like they were drowning. And it was scary. And I also ended up sleeping like 16 hours a day.
And I'll just add, because I know your story quite well, not nearly as well as you do, but that fear that surrounded you, that desire to control you, was manifest not just in a succession of pills, but in an actual pileup of pills, so that it was sort of one medication upon another to try really, as you say, on behalf of those around you, not on your behalf, to control. More on that in a moment. How, tell us a little bit about how you've worked to claim and to assert your own understanding of your mental health. And maybe tell us a little bit about how difficult this journey has been.
Thank you, Daniel. Yeah, oh my days, it has been wild. So let me paint the picture. I'm not a doctor. I'm not a psychiatrist or a psychologist. I'm not an auxiliary health worker to these fields whatsoever. Yes, I am a certified mental health coach, but I'm not some medical student. And the reason I say this and I start with this is because fundamentally, I have simply been a person with a lived experience who has created a groundbreaking movement in Nigeria that has affected the lives of over 40 million Nigerians, right? I'm a person who refused to stay in the shadows of a system that's riddled with abuse and allows my lived experience to be reduced to nothing. But guess what? According to how the mental health system has largely worked, I have no right to be anything other than a patient. So I comply with my doctor's orders and I thank the system for, sort of like doing me a favor. And to put it very simply, Daniel, it has been nothing short of brutal. I have dedicated years of my life re-traumatizing myself as a person that lives with bipolar and post-traumatic stress as well. I have dedicated my life re-traumatizing myself with hundreds of lived experiences of people with mental health conditions. I have seen firsthand how mental health services and laws can be degrading and abusive. I have been excluded from vital mental health conversations because you are not a professional. And if the right to speak about, as if the right to speak about my condition that underpins my very existence is somehow an exclusive right of a psychiatrist or some other medical practitioner. I have seen the life-threatening effect of the lack of informed consent and involuntary detention on people with mental health conditions. I recall a psychiatrist telling me that I was misleading people on national radio because I referenced research and evidence that psychiatric facilities were actually complicit in abusing people with mental health conditions. So it's been brutal, it's been tough. I have learned and learned and learned. I have asserted, I have spoken up. I have put myself in danger mentally, physically, psychologically, emotionally. My loved ones and I have taken lots of hits to be able to stand firm on this. And we need to recognize that, yes, indeed, on an individual level, there is a problem when we seek mental health support. But we must always put into context the entire system that backs the individual to strip people of their rights and to diminish people on the premise of things that are not valid or evidence-based and not person-centered or rights respected. So from where I'm seated, I can tell you for sure that the simple claim that people with mental health conditions have full and equal rights on an equal basis as others and can be active participants and co-creators in their own mental health journey is perhaps the most threatening ideology to the biomedical model of mental health. And that is everything you need to know about how difficult this journey has been.
Again, thank you, Hawa, and I'm sorry for the brutality of that journey. I just want to add one note when we all say we're urging a movement beyond the biomedical model. The key word here is beyond. It's not leaving medication completely behind. It's not preaching against medication. I know from spending lots of time with Hearing Voices groups and with Hearing Voices members, that group, the Hearing Voices Network, that Caroline is so essentially involved with, that there's a mix. Some people take medication, some don't. This is not a session of preaching against medication, but it is an attempt to get people to reorient themselves away from the dominance of that model. Caroline, can you talk a little bit about how you yourself have moved beyond that biomedical approach and about what helped you, who helped you to move beyond it?
Yeah. So for me, I had to first understand that what people were calling the medical model wasn't exactly a model in terms of like they could tell me what exactly was wrong with me. Like to me, instead of a model, it was more like a power structure where the people with the most medical training, they were at the top. And then people like me that didn't have that, the experiencers, we were at the bottom of that power structure. So I was supposed to listen to doctors, but it seemed like there wasn't exactly a model because they couldn't agree on what my diagnosis was, or whether I had bad neurochemicals or bad genes. It was all really confusing. So instead, I started to listen to other people who heard voices and were living okay lives. People that were focused on building community instead of balancing chemicals. And as you mentioned, Daniel, like I had a lot of support in the roller derby community. So at Wildflower Alliance and Hearing Voices Network, we actually talk really openly about our voices and our visions. We believe that it's also a human right to have our struggles have meaning again, instead of just being reduced to dopamine receptors or DSM billing codes. So an example is if I'm hearing a voice and that voice is telling me to kill myself, sometimes there is something in my life that needs to end or die, but I don't have to take that voice literally in what it's saying. If I'm hearing a voice and it starts to tell me to throw myself out the window of my office, maybe I can go downstairs and just kind of jump off a short stoop to sort of reduce the harm of that voice. And just one more example, like if I'm feeling unsure whether other people can hear the voice that I'm hearing, I can use, if I have my cell phone, I can put on voice record on my phone and I can see if it picks up any sound waves in the environment. So at Wildflower Alliance, we gather up these tools that we use to survive, and then we teach them back to providers so that they have something to use other than just drugs. And as I said, like I'm not anti-drug. Drugs make me fall asleep. So I do see a prescriber to get sleeping pills for those nights when I don't sleep. But I also no longer assume that just because someone can prescribe drugs, that means they're an expert on my experience. So my problem with the biomedical model, it's not about pills, it's about power, about who is holding all the power to define what a problem is and what to do with it.
Right, and just to underline, I think one of the many points within what you just said is you have found your own calibrated way to more than cope, obviously to flourish. So sleeping pills, sleeping aid is a part of it because sleep is essential to coping. That pileup of other pills is not a part of it. Roller derby, if I can explain, was a part of it, as you've said, Caroline, because it's sort of, roller derby, if you can imagine, is kind of an anarchic, it's a rugby-like sport, and in a way it kind of taught you to marshal, to manage chaos in a creative and productive way. In so many ways, you are teaching us, you've certainly taught me, the creative means, the non or less medical means that can come into play so profoundly. How back to you? In a world An imagined but not too far off world where the WHO guidance prevailed, where the WHO vision influenced policy and law, how, in that world, might your journey have been different?
Yeah, so at my organization, OHCHR Rights Women, we have documented, incidences and lived experiences of people who have experienced varying levels of abuse or degrading treatment or, you know, sort of like their rights being denied. So everything from involuntary detention to lack of informed consent and, torture, shackling and things like that. So one of the stories that really stands out for me is the story of Remy. And she shared her experience with us at She Rights Women, where she was detained in a state-owned facility in Lagos, Nigeria. And not only was she involuntarily detained, she was stripped of her informed consent. As if that was not bad enough, she wasn't allowed to wear her clothes or have access to her personal belongings, including her phone. And you know how they made sure of it? They chained her to the hospital bed, had a heavy built male personnel hold her legs open, whilst a nurse pulled down her underwear in the presence of the entire ward. She screamed, she cried that day it happened, and she cried the day she also told us about her experience. So Remy may never recover from the trauma of that event, and she may never get justice for what happened to her. Now, in the world where WHO guidance was a reference standard of mental health care, I envision that Remy need not even fight for justice, as she wouldn't even have been subjected to that degrading treatment in the first place. So in that world, I would have been, in my own personal experience, been more informed about my medications and their long-term effects on my life. So I could have made better decisions about taking medications. Again, like we have reiterated, not anti-medications, not anti the biomedical model, but realizing that there has been a dominance. And just like Carolyn said, there has been a severe power imbalance in, the entire profession of mental health or medical mental health, and we, the people that actually live with mental health conditions. And perhaps I would not have been sidelined many times, repeatedly, as less than a mental health practitioner simply because they had a medical degree, while I had spent my entire life living with this mental health condition. And I probably would not have had to live through being vilified for merely standing up and speaking up for not just myself, but over 40 million Nigerians and hundreds of millions of people around the world. So maybe hundreds of people who may never recover from the abuse, torture, and inhuman treatment that the mental health system and the lack of right respecting and person-centered laws to protect them. The mental health system is largely known for that, but maybe now, people would not have to live with that anymore. And, the thing I keep coming back to is not because, like Michelle had said earlier, it's not that this guidance gives us something entirely new. Indeed, it is a blueprint, but it reiterates all the milestones that have come before. But what is shocking to me, and what I tried to also reiterate or communicate before, is the need for certain groups of people to speak to certain groups of people. And it's sadly or not, people with mental health conditions have not been listened to within the medical community as far as mental health is concerned. So it is nice to know that at least when there is pushback, I can say, well, the WHO, the body you draw your own standards from, said so. And it could stop them in their tracks. It might be a little bit painful because, again, we are reiterating things that people with mental health conditions, we the people who have been told that we can trust ourselves, we can trust our minds, we need medications, we need to be sedated, and all of those things that have followed and perpetuated the stigma and prejudice towards people with mental health conditions. But we've been saying this for years, and we have not been listened to. We have been told, let the professionals speak. And so while this is really, really a very sad thing that has happened, it is also something that I hope that the backing of this guidance would push, especially within the medical community. And even though it would not be because we were being believed for it, and we know our experiences, at least there is a backing, institutional backing, to say, this is what we have been telling you all along. So in that world, rights are respected. In that world, information is given so that consent is informed. I mean, what is consent if it is not informed, if it lacks transparency, if it's under the threat of coercion? You know, and so there is a lot of that that needs to be taken into consideration. And what the World Health Organization has done by this is that it is knowingly or unknowingly speaking directly to the medical community to say, okay, now we have put our foot down and this is what it is. And so I'm really hoping that we can begin to see that world and we can begin to chart a future where all of us begin to get on the same page about our own rights as people with mental health conditions.
Thank you. And I'll just quote you back to you. This is what we have been saying all along. Would I think be a key takeaway for the day. Caroline, once more back to you. You reached a crossroads not so long ago, a crossroads that is very relevant to us today. You were hearing voices that were violent, that told you to kill before you were killed. And in our current world, certainly in the United States, you were a candidate for involuntary commitment. Can you tell us about that time and where you found meaningful help?
Absolutely, yes. I have heard voices that have told me to kill people that were out to get me. The last time that they were incredibly loud was actually when I was providing some support to fellow survivors who were living in a locked long-term unit, providing peer support. One of the people that I talked to really frequently who lived on that unit was violently restrained for arguing with a nurse. And they left him alone, tied to a bed. So I sat on the floor so that, like, next to him, talking to him so that he would be less lonely. But the hospital staff then became angry at me, saying that I was doing something dangerous and unprofessional for comforting the man that they had tied down. But within 2 hours of that, I started to hear very loud voices saying people would be coming to kill me. And the voice said that I would have to defend myself with a knife specifically. And I think if I had been detained in the hospital that day, I might have been aggressive and scared. I was lucky though, because I had the option to go to a FIA house instead, which is a peer respite. And that's a place where I could get support with the voices, but I could also, in a peer respite, you can lock your own door, like against the world, so that you can feel protected. You can lock your own door, but no one locked me in. So I was a lot less afraid. And then there were peer support people that I could talk to that were not afraid of voices. And so they asked the voice, like, if there was anything that he needed, the voice I was hearing, if he needed something to calm him and his fear. And the voice said, Freebird. He wanted to hear the song Freebird by Leonard Skinner. This is an American band. He wanted to hear it played on the guitar. And so that's what people did. There was someone there that could play the guitar and kept singing the song. And as they did that, like, it helped calm my voice. And that gave me an opportunity to actually like cry about the pain that I had experienced and witnessed. And that's what I really needed. And I think, you know, these recommendations are so important to create those spaces for other people. And I also, even more broadly, I want society to take some responsibility for the violent voices that some of us are hearing. Because I did not hear violent voices until other people hurt me or hurt the people around me. I didn't hear them until I saw senseless war and senseless violence. So we really need more places like a FIA house where we can be sheltered from violence and control instead of being exposed to more of it, because a lot of these voices, they're only reflections of violence in the outside world.
Thank you, Caroline. And I'm also going to very briefly quote you back to you. So you taught me, when we are controlling, we are not connecting. I think our impulse, whether it was my family when my brother was going through his crisis, or whether it's our system in general, our systems, our societies, is so eager to control, but it inherently, as Caroline has taught me, prevents the very connection that can be so transformative. And Caroline's story just exemplifies that, the connection found at a FIA house, the kind of approach that's too scarce but is out there to model ourselves on, that kind of approach, that connective approach, not the lock you up on the safe and well-controlled locked ward. It's that approach, that innovation, that connection that we need. Thank you so much, Hawa and Caroline. Our third and final panel. I'm pleased to introduce eminent representatives from different sectors to hear their reactions about the significance of the joint WHO and OHCHR guidance on mental health, human rights, and legislation. First, I'd love to hear from Her Excellency Dr. Margarida Tavares, the Deputy Minister and Secretary of State for Health Promotion of Portugal. Your Excellency, Portugal, jointly with Brazil, has led the drafting and adoption of no less than 4 UN human rights resolutions on mental health and human rights during these last few years. The most recent was adopted in April of this year. And if you could share with us, why is Portugal so invested in this area, and what does this guidance mean for mental health in Portugal?
Thank you, Chair. Can you hear me? Can you hear me?
Yes, we can. Thank you.
Okay, thank you, Chair. Dear colleagues from the panel, excellencies, ladies and gentlemen, thank you for this opportunity to discuss Portugal's commitment to mental health. Our efforts are driven by 3 factors. First, we believe in the human right to the highest attainable standard of physical and mental health as a universal value. All states must abide by their obligations under international law to respect, protect, and fulfill this right. It transcends borders and affects individuals, families, and communities. Second, mental health is not an isolated issue. Neglecting mental health perpetuates inequalities and hinders social progress. Portugal and Brazil's resolution focuses on the need to respect the human rights of persons with psychosocial disabilities and current or potential users of mental health services. Addressing mental health from a human rights perspective is not only a moral imperative, but also essential for achieving sustainable and inclusive development. Third, we want to reinforce the positive tendency in the world to recognize the importance of mental health. Existing legislation often falls short, and this perpetuates human rights violations, including the denial of the individual's autonomy and legal capacity, coercive practices, and institutionalization and substandard services in mental health facilities. In response to these challenges, we are proud to have consistently advocated for a human rights-based approach to mental health. Our commitment extends to the UN agencies that champion this issue. We welcome and support the efforts of organizations such as World Health Organization, the Office of the United Nations High Commissioner for Human Rights, the United Nations Population Fund. The publication we are presenting today is a crucial tool to assist countries in implementing mental health-related legislation and policies. For Portugal, this guidance will reinforce our commitment to transforming our mental health policy and services. By aligning our practices in this field with international human rights law, with the UN Convention on the Rights of Persons with Disabilities as outlined in the UN resolution and guidance, we are working to ensure that every individual in Portugal has access to high-quality, right-based mental health care and support. On a national level, Portugal has been implementing a mental health reform, taking tangible steps to end institutionalization and investing in local and community-based support services. An important part of this reform was the recent approval of the new mental health law. This law provides better protection for the rights and autonomy of individuals. Notably, the new law eliminates the possibility of indefinitely extending security measures for those found not criminally responsible. In conclusion, modernizing mental health approach on a global scale requires a collective effort to incorporate participation, informed consent, decision-making, and community inclusion. Additionally, we must address the social determinants of health more effectively, working to reduce poverty, violence, stigma, and various forms of discrimination. Thank you very much.
Thank you so much, Dr. Tavares. We'll now turn to His Excellency Ambassador Tovar da Silva Nunes, the permanent representative of Brazil to the United Nations at Geneva.
Thank you very much, Mr. Moderator. Please allow me, as I extend my greetings to all distinguished participants, to show our appreciation for the commendable work done by WHO and the Office of the High Commissioner for Human Rights, but also for allowing us to hear such eloquent and inspiring testimonies of people with lived experience. I think that's very important for us as we continue to work. And as you know, Brazil and Portugal are partners in these intersection of mental health and human rights. I'm truly honored to speak on behalf of my country, a country that has had a very progressive journey in this area, and hoping to coordinate and work with other countries willing to take the same road. I think we can all agree that mental health is emerging as a critical global public health concern, but also a human rights, in need of a human rights perspective. And it's also a human rights imperative on its own. And despite significant progress in the past decades around the world, individuals seeking access to mental health services continue to encounter numerous barriers and difficulties. And so we have to keep that in mind and acknowledge that we still have a long way to go to ensure that legislation and policies on mental health are completely aligned with the highest human rights standards, and that they are implemented accordingly. And this guidance that is being launched, jointly produced by the WHO and the OHCHR, will be of great help in this endeavor. Legislation clearly has played a pivotal role in Brazil's transformation of its mental health model, but also in reinforcing the rights of individuals accessing mental health services. It initiated a forward-looking approach leading to substantial increases in budget allocation for mental health care, with a focus on community-based solutions over institutional ones. In Brazil, where we have made significant strides in the development of a community-based mental health system, this guidance can be instrumental by charting a new course that emphasizes human rights, person-centered care, and the realization of individuals' full potential. Presently, Brazil's extensive network of psychosocial community centers, which serve as the cornerstone of our community mental health model, is globally acknowledged as a best practice model, endorsed by the WHO. This joint publication also sets the stage for deinstitutionalization and the establishment of high-quality, person-centered community mental health services, offering insights into how countries can adopt a human rights-based approach when reviewing, adopting, implementing, and evaluating mental health-related legislation. We sincerely hope that this relevant partnership that the WHO and the Office of the High Commission have begun on mental health can extend. This is a suggestion we make, can extend beyond this guidance, making way also possible for cooperation with the International Labour Organization, ILO, to promote enabling working environments for those with mental health conditions and psychosocial disabilities, with full observance of the provisions of the Convention on Rights of Persons with Disabilities, which has been ratified already by 188 countries. Those are the remarks I wanted to share with you. I thank you for the opportunity.
Thank you so much, Mr. Ambassador. I'm glad you shared that, your endorsement of and your country's exemplification of this transformative work is so crucial. With that, let me turn to Israel, to the words of Her Excellency Meirav OHCHR, the Ambassador and Permanent Representative of Israel to the UN Office and other international organizations in Geneva, and to the words of her representative this morning.
Thank you, Mr. Moderator. Clearly, I am not Ambassador OHCHR. I'm delivering this statement on her behalf. She apologized for her absence, but given the current situation, she cannot stay seated in this event while Israel is suffering terrorist attacks. On Friday, and this is what she wrote, I had my presentation ready and adjusted to the time limit. Sadly, on Saturday, we woke up to a new reality. The terrorist group Hamas spearheaded attacks initiating a new war with Israel. These lawless terrorists started indiscriminate attacks against innocent civilians in Israel, both by showering rockets on our skies and by infiltrations in our cities. They have injured more than 2,000 and murdered more than 700 innocent persons, including children, women, older persons. They have burned houses, kidnapped more than 200 people who have been taken hostages back to Gaza. We're still in shock with the brutality they are showing, but we will not falter in our commitment to protect our population. We have received already many expressions of support from different countries and condemnations of these actions. But we expect that this time, the international community does not fail the Israeli people once again. There can be no doubt of the violence of these terrorist actions. We need to call things by their name. Hamas is a terrorist group, and nothing can justify these actions. We hope that the UN condemns Hamas actions as well. Now, regarding the guidance, we would like to thank WHO and OHCHR for developing this document and congratulate the whole team that worked on preparing it. We actually read the 200 pages. Israel is committed to promoting a human rights-based approach to mental health, and we supported its inclusion at the Human Rights Council resolution this year. We joined the core group of the UNGA resolution at here at WHO. We led on the first resolution on the highest sustainable standard of health for persons with disabilities that was following a human rights-based approach. Moreover, as you have mentioned, Israel has made progress regarding mental health, yet, probably as every country in the world, we still have a very long way to go. Israel has always been a strong supporter of the Quality Rights Initiative, and we see this guidance as the next step, as an important tool in addressing necessary reforms and encouraging states to do more and better on this essential issue. We would like to highlight some of the key elements that we have identified on the guidance. First, that it's fully embedded in a human rights-based approach, which recognizes the importance of a cross-cutting perspective and the need to go beyond the medical model. It also considers the impact of intersectionality, including age, gender, and disability, but looking beyond them as well. The guidance includes all the steps of a legislative process, from the initial discussions to the implementation and resources allocation. We also appreciate the usefulness of the inclusion of a general framework, both from the international human rights law side and regarding WHO works that could help member states to explain internally the need of promoting that reform. In this regard, the inclusion of example and good practices from other states is central for us, as it provides us with the opportunity to show how other models are possible and to combat fears of recognizing challenges that may impair progress. In the case of Israel, we have recently gone through the first review before the CRPD committee, and mental health was one of the issues that we discussed. As part of the dialogue, we reaffirmed some of the challenges that we're facing, including the need to deepen on the process of disinstitutionalization and to promote the shift of paradigm from the medical to the social model in practice, including in the health sector. Furthermore, we agree with the guidance emphasis on promoting meaningful participation, as well as on the need to promote training and awareness raising as key in any reform process. Israel already does so, but the document will help us to push even further. Finally, we believe that the inclusion of some points in the guidance will be fundamental for states when considering the reforms. Among them, we would like to highlight the need to establish mechanisms of legislation and review, the importance of informed consent, community-based systems, peer review, and attention in crisis. In these days, when Israel is suffering indiscriminate attacks, where Israelis are suffering shooting, murdering of relatives and friends, when they have spent hours hiding trying to escape the slaughtering hands of the Hamas terrorists, when many people have been kidnapped, mental health services in crisis situations will be a key instrument to deal with this situation. We still do not know the extension and consequences of this war, but we will need to keep protecting and assisting our population, including regarding their mental health. To conclude, I would like to thank you once again, and you can be reassured that we will be sharing the guidance with all the relevant ministries in Israel so we can continue working on ensuring that quality mental health services are provided as part of our commitment to fully realize every person's human rights. We hope that the time to go back to work in peace will arrive soon. Thank you.
And thank you especially for that reminder about the urgency of our topic today. I'd now like to introduce the words of Attorney Richard Palpalatuk, who speaks to us with the perspective of the Philippines and who is the chairperson of the Commission on Human Rights in the Philippines.
I am Attorney General Parahino, Director for Policy Office of the OHCHR. I am speaking in behalf of the chairperson who unfortunately has an urgent meeting just right now. So in response to the question, the Philippines enacted its first ever Mental Health Act in 2017. This was a significant milestone as for the first time, the rights of people with mental health conditions were guaranteed in law. The new act addresses a wide range of crucial issues and protects a number of key rights, including access to mental health services and to aftercare and rehabilitation, freedom from discrimination and stigmatization, freedom from solitary confinement and from torture, cruel, inhuman, the right to free and informed consent and to participate in the treatment plan to be implemented, the right to confidentiality, and right to participate in mental health advocacy, policy planning, legislation, service provision, monitoring, research and evaluation, among other key rights. The Philippines was an early ratifier of the CRPD, or the Convention of the Rights of Persons with Disability. And it was therefore crucial that we work towards meeting our commitments under the convention and aligning the new law with its provisions. However, we did struggle with how to put some of the CRPD rights and principles into practice. So, for example, the right to legal capacity and to supported decision making are complex issues, and not everyone knew about the CRPD or understood these rights or concepts. Not only that, but there were diverse views on these issues, which required a significant amount of discussions and debate among stakeholders during the drafting process in order to truly understand the implications for the law. What is so significant about this new WHO and OHCHR publication entitled Mental Health, Human Rights and Legislation, Guidance and Practice is that it provides concrete guidance on what these concepts mean for the mental health field specifically, and how this can be translated into concrete provisions of law. This is exactly what we needed at the time of drafting of the content of our law. And not only it is an invaluable tool in terms of guidance and it provides on law content, but also in terms of the concrete recommendations that it provides on procedural matters relating to implementation. In particular, we also wish to commend the inclusion of a checklist for assessing a rights-based legislation on mental health. Not only does it provide for a concrete way of assessing a legislative measure, it also provides a clear and common objective for various stakeholders involved in the legislative process. For sure, it will be helpful right now as we progress with the implementation of our law and as we lobby for a mental health ordinance in local government units. Our key message is that, based on experience, this guidance will be an invaluable tool for countries embarking on mental health law reform. Thank you.
Thank you so much for the perspective of the chair of the Commission on Human Rights in the Philippines. And with that, I'm very glad to be turning to Dr. Dixon Chibanda of Zimbabwe, a psychiatrist, a professor, the founder of the Friendship Bench in Zimbabwe, and the director of the African Mental Health Research Initiative.
Thank you very much. It's really exciting. And, you're absolutely right on everything that you've been saying. There are enormous challenges with serious lack of mental health resources and services, and not only a psychiatrist's view, but all mental health professionals more generally. But even in such a resource-limited context, this new guidance has the potential for fundamentally changing the area of mental health and the mental health profession as a whole. The enactment of this guidance has the potential to fundamentally change the relationship between mental health professional and the people that they serve. The practices of psychiatry and other professions will no longer be to tell a person what treatment they must take, nor what they must do or stop doing. It will be instead to listen to the person, to understand how their mental health issues are affecting their life, and to support them in identifying and determining what they would like to improve, to change, to address in their lives. It will no longer be about just handing out medication, but instead about understanding what a person's support needs are and discussing how these can be met, giving people a broader array of choice, including working on things like relationships, family and social networks, physical health, lifestyle, and emotional well-being. or working with the person to understand and respond to the underlying factors contributing to their mental health status. For example, the experience of discrimination in their life, violence, abuse, or neglect, poverty, and inequality. All these factors and more can directly lead to mental health conditions or worsen existing mental health issues. They must be addressed to have good outcomes. What is also exciting is that this guidance also promotes a radically different approach to how we manage an emotional crisis. If someone is experiencing a crisis today, for example, in my country, Zimbabwe, but also in a lot of other countries, professionals too quickly tend to turn to coercive measures like involuntary admission and treatment, seclusion, and restraint. However, this new guidance would result in a significant different practice and approach. For example, mental health care staff would potentially de-escalate any conflictual situations before they evolved. Conflictual situations are often a trigger for involuntary admission and treatment, mainly because they aren't handled well. Healthcare staff would also make more effort to establish an empathic dialogue and personal connection to carefully listen and understand what people are going through. Also, a support network around a person or their choosing would be drawn upon to help understand the person's will and preference for treatment and support. Various care and support options would be offered, including both medical and non-medical. A support plan would be developed detailing different treatment and support options, community resources, personal assets, and networks that the person could draw on. But ultimately, changing law according to this guidance will be hugely helpful in changing clinical practice for the better. Without resorting to coercive measures, relationships between service users, psychiatrists, and other healthcare workers will not be undermined, but instead strengthened and built upon through trust and collaboration. Thank you.
Thank you so much, and it's great to hear these convergent voices from all over the world. We're running, I should say, to our guests just a few minutes behind, no more than 10 minutes. One last panelist, a very important one, Professor Gerard Quinn, the UN Special Rapporteur on the Rights of Persons with Disabilities.
Well, thank you, Mr. Moderator, and congratulations on a very stimulating and useful launch. The launch of this guidance today, I think, is a very significant moment in the evolution of mental health law, policy and practice around the world. It marks a step change in our global policy imagination on mental health. It's one of the defining issues of our times, and it's at the confluence of so many intersecting domains, especially today as conflict rages and has a deeply traumatizing and intergenerational effect. Why a step change? I think, first of all, the guidance marks a profound moment when human rights becomes more than just tools to control the coercive power of state. The first phase of human rights as applied to mental health is now over. This involved accepting intrusions onto liberty and forced treatment and developing limiting principles to minimize their use. Important though that was, it has never exhausted the full potential of human rights in this field. The new agenda, which is well set out in this guidance, is about how to breathe life into rights, and especially for those with mental health issues. To me, this is human rights at its very best, informing and guiding the constructive power, use of power and largesse to serve the dignity and autonomy of all persons with with disabilities. Arguably, this was the original design of the Universal Declaration of Human Rights. Secondly, it gives states and others confidence that the parameters of the new approach to legislation and practice are well known, tested, and indeed successful, a marriage of vision with practicality. I can attest from my own country visits as Special Rapporteur that there is a huge hunger out there for practical guidance that goes beyond generalities. Most are acutely aware of the need for change. This guidance gives those who are motivated to seek a new path the practical tools to think through law reform and policy. To me, this is the WHO and the UN Office of the High Commission at their very best, crystallizing the need for change and equipping policymakers and others with the practical tools to enable it to happen. Thirdly, the guidance does not shy away from hard or difficult policy choices. Its honesty shines through, but by providing a different framing for the issues, the guidance provides the basic tools to think through some of these policy dilemmas. Solving them will be an ongoing process. Finally, no process of change is complete or even legitimate without the active involvement of persons with disabilities from the very outset. I have always emphasized that the process innovations and not just the substantive innovations of the UN Disability Treaty are the most important thing to keep alive, to keep change alive, rather. This points to a radically different future compared to the past, and the future is one of co-production. In a way, this guidance is a model for other domains and will transform how broad health policy is imagined, framed, and articulated. Given the imbalances of power in the past, and especially in the mental health field, this can only be a good thing. We have yet to focus on moral repair for past wrongs in the mental health field, but that will come in time. I encourage all states, professional groups, and civil society to use this guidance to steer reform. Change means learning, and we can all learn from each other. In this respect, the guidance is not an end point, but a departure point, a new departure point for the world, and I greatly welcome it as such. Thank you so much, Mr. Moderator.
Thank you, Professor Quinn. I'll borrow one of your phrases. Honesty does indeed shine through this document. And in closing, just 2 more minutes of honesty. It has been illuminating to hear our speakers, and it was reassuring and inspiring for me to read this guidance, this call for transformation. But perhaps, and here the note of honesty, we haven't talked enough about fear. The fear that in making the major changes outlined here, we will somehow go astray. Will the move away from involuntary care mean a rise in people harming themselves? Will the move beyond the dominance of the medical model mean a rise in people harming others? Will engaging deeply while giving people decision-making power in their own mental health care mean a surge in societal chaos? Almost certainly not. Too often, our current way of doing things compounds feelings of isolation. Too often, it creates feelings of helplessness and lack of agency in one's own life. And isolation and helplessness lead, in turn, to the very outcomes we are afraid of. What does it mean to take a human rights-based approach to mental health care? To avoid obvious cruelty is only a start. To state the inherent value of human beings is only a start. A truly human rights-based approach means believing deeply in how much we all have in common. It means recognizing as a fundamental principle what we share, our infinite complexity and immeasurable potential. It means putting aside fear in order to help others just as each one of us would probably wish to be helped in the midst of a mental health crisis. We human beings long to be deeply heard, not relegated to a real or metaphoric box. We long to connect, not to be controlled. We long for the possibility of charting our own paths. To make these very basic human desires the true basis of mental health care is going to take a leap of faith. Can we take that leap? This guidance, launched by the WHO and the OHCHR, is a much-needed step. I hope we will all take bold steps away from our own fears and toward establishing mental health care that is all about the people, people like us who yearn for nuanced, complex understanding, people who long for the offer, not the enforcement, but the offer of our help. Thanks to all of you who will bring this guidance into the world.